Hello, apologies everyone. There was some technical issues. Sorry, can I be heard now? Can everyone hear me? Wonderful. Apologies about that. I thought I've gone live, but I haven't, apparently. So I'm just gonna start from the beginning. My name is Lin, and I'm one of the academic clinical fellows in neurology and a current IMT3 and soon to become a neurology registrar at Sheffield Teaching Hospitals. And today we'll be discussing cognitive and behavioral disorders, dementias, and we're going to dive a bit into auditory and visual cognitive impairments. And what I want you to get out of this session is basically be able to assess someone that comes to you with cognitive impairment or delirium and know exactly what workup you need to do in order for you to be able to direct further management and know the evidence-based workup and the evidence-based management, and then understand that course of the disease to be able to appreciate the prognosis and how to deliver that to patient and what can we do to help these patients. So starting with the definition of dementia, it's basically a complex process and it involves quite a complex interplay between molecular pathways that affect the cellular functions in the brain, and therefore this could lead to loss of synaptic connections, cell death, gliosis, inflammation, and disruption of functional networks that underlie the cognition and the personality, as well as the behavior and sensory motor functions. And eventually that starts attacking the individual's autonomy when all these domains become affected. And aging by itself is the most robust risk factor for dementia. With more than 90% of dementias, they present after the age of 65 years old. And according to a 2015 World Alzheimer's Report, which is a comprehensive meta-analysis, it estimated that at least now 46 million people worldwide are living with dementia, but they expect that number to almost triple by 2050 to at least 131 million. So as we can see, this is something that's now becoming more common because we have a more aging population, but it has its own implications on the patient's lives, the patient's well-being, the patient's quality of life, and their carers' quality of life. So understanding the cognitive impairment and dementia better will help us be able to help these patients live with a relatively good quality of life for as much as possibly we can. And I'm going to also go through some of the risk factors that could potentially be contributing to this that we could try to prevent early on. Historically, the definitions of dementia have been weighed mainly towards memory, and that's what we usually see in typical amnestic Alzheimer's disease, but that was revised in 2011 and started to reflect the plethora of cognitive and behavioral changes that caused the decline from the baseline levels of functioning. Now, the revised definition requires impairment in at least 2 neuropsychiatric or cognitive domains that we cannot explain by a non-degenerative or primary psychiatric disorder or a systemic condition such as delirium. Now, the diagnostic process is therefore requires us to have a very thorough history from the patient and preferably also a reliable informant, as well as an objective measurement of that impairment. And we have specific neuropsychiatric and neuropsychological assessment tools that helps us objectively assess the degree of impairment in each patient. And having a look at all patients who present with dementias, most of it has either a degenerative or a vascular cause, but there are other causes that we see, such as infection, inflammation, neoplasms, toxic insults, metabolic disorders, and trauma. And actually, 11 to 14% of dementias are potentially caused by reversible conditions, and therefore we need to rule out these conditions. It's very important because before we label the patient as dementia, if there are things that we can reverse to prevent any deterioration, we should. Now, what I want you to know from this has too many details in relation to the genetic basis of some of these neurodegenerative conditions causing dementia, but this is something, this is just to show you different pathologies that cause different presentations. with amyloid beta, for example, prion proteins, alpha synucleins, and Lewy bodies, tau. All of these are misfolded proteins that accumulate at a very high degree in the brain, and this is what causes the neurodegenerative process to go. And there are many genes that has been implicated in different neurodegenerative conditions, none of which you need to know about in detail, but obviously anyone who has a strong family history of early onset dementia, we then need to consider checking these genes to see whether there is any connection to that, because obviously that has an implication on the wider family and conception and so on and so forth. But the most commonly known causes of neurodegeneration that causes dementia is prion disease or Creutzfeldt-Jakob disease, and there are more than one type of Creutzfeldt-Jakob disease. There's fatal familial insomnia, Gerstermann-Straussler, Schenker syndrome, and then Alzheimer's disease. And Alzheimer by itself can have many subtypes, like an amnestic late onset, a behavioral dysexecutive Alzheimer's, logopenic variant, and a posterior cortical atrophy variant. And then we have the frontotemporal dementia, which, as you all may know, we have a behavioral and a non-fluent variant of it. There is a semantic variant. There is one that overlaps with the presentation of MND. There's corticobasal syndrome, and then there's progressive supranuclear palsy syndrome. And then lastly, the Lewy body dementia and Parkinson's disease dementia. So as I discussed earlier in the earlier slides, the etiologies can span quite a lot of things. And when we are taking history and do a physical examination, we need to try to narrow these down to know what to investigate for, so we know what to label the patient, because that can help us provide the best treatment for them. So obviously, vascular causes like small vessel disease or history of strokes in the past could potentially increase the risk of developing cognitive impairments and dementia. If there is any neoplasm, that would cause more likelihood for patients to present with cognitive impairment. Psychiatric causes, for example, anxiety and depression, if it's long-standing and not very well treated, we actually see patients that present with what we call a pseudo-dementia, so that because of the depression that hasn't responded to medications or has been going for a very long time, they will present with what looks like a cognitive impairment, when in fact it's, and that's why it's labeled pseudo-dementia, but they actually don't have any organic causes for the cognitive impairment they're struggling with. It's mainly related to ongoing and long-standing depression. Neurological, so things like normal pressure hydrocephalus is something that could cause quite a significant cognitive impairment and is reversible, so it's important to rule out. Any toxins, like toxic long-term exposure to toxins like lead and mercury, could potentially lead to buildup and causing cognitive impairment, and that used to happen more often in the past. Inflammation, so diseases like multiple sclerosis and inflammatory conditions generally in the brain tend to put the patients at a higher risk of developing cognitive impairment. Infections, so different types of encephalopathy or encephalitis, like anti-NMDA encephalitis, herpes encephalitis, all these could potentially cause long-term cognitive impairment. Traumatic brain injury is one of the leading causes of cognitive impairment, and people who have traumatic brain injury on the long term are put at a high risk of developing that. And then any endocrinological, metabolical, and nutritional deficiencies could present that way. So B12 deficiency, folate deficiency, sometimes electrolyte imbalances by themselves could potentially cause that. So we need to be thorough when we are assessing as well as working up these patients before we label it with a specific subtype. So for us to be able to assess this, we need to have an understanding of the urgent considerations in this aspect. So we need to understand what delirium is, and it's usually an acute, reversible, metabolically induced state of fluctuating consciousness, and it involves rapid changes in the level of consciousness and in the orientation. And usually, if we have any signs on physical examination or history indicating a general medical condition, such as infections, for example, metabolic disturbance, pharmacological toxicity, and we see that quite a lot with elderly patients, that sometimes can be elucidated further and we can work around it and reverse the cause. Herpes simplex and virus encephalitis is something that we also need to keep in mind, and it's very important to rule out, as it causes a febrile illness in an acute way, and it causes altered mental status. And patients usually present with a headache, seizure, and sometimes focal neurological signs. And a variety of cognitive deficits may actually persist even after the acute stage, and they are often the sole cause of disability for patients after being treated for herpes simplex encephalitis. So obviously, considering that early on, so doing a thorough history and physical to make sure that this is excluded or needs to be included in the differential and therefore working it up is very important, because if treated promptly, the chances of it having a persistent problems or cognitive deficits becomes less. But we need to be very prompt about doing what's necessary in terms of investigation to be able to treat it promptly to minimize any long-term complications. Wernicke's encephalopathy is something that you might see often. It's subacute onset, and it has the classical triad of ophthalmoplegia, gait ataxia, and delirium or mental state changes. And people who are nutritionally depleted sometimes have a presentation that way. It's usually associated with alcohol misuse, which all usually these patients also have nutrition depletion. The mental status changes includes inability to concentrate, apathy, impaired awareness of the immediate situation, spatial disorientation, delirium, frank psychosis sometimes, and even coma. So we need to consider, if you see this triad, make sure to assess them for Wernicke's and start the appropriate treatment. Depression, as I mentioned to you before, if it's present and it's causing a degree of cognitive impairment, we can call it pseudodementia, and it's a reversible cognitive impairment. And once we treat that depressive episode, usually the cognitive impairment ceases. And conversely, depression can actually be an early presenting symptom of dementia. So the timeline of how all these things come together is also very important. Agitation is a common among individuals with dementia, and it can occur at any time during the illness. However, you need to rule out secondary causes for that, especially among elderly patients, including things like underlying medical disorders, them being in pain, drug effect, constipation, urinary retention, and so on and so forth. And the diagnosis, now we're going to discuss the clinical approach, knowing all of these things and the secondary causes of cognitive impairment and delirium, and how they can present in an acute or subacute way. When we diagnose, we need to consider first that we compare the patient's current level of cognitive and functional capabilities with their pre-morbid or baseline level. So if there's a significant decline that's noted, then a diagnosis of dementia can be considered, but we need to do a thorough history, cognitive examination, physical examination, laboratory tests, and neuroimaging. And we need to also review their medications, because sometimes certain medications can actually cause them to become more cognitively impaired. So things like anticholinergics can usually cause a degree of cognitive impairment, especially if given in elderly. So when you take history, you need to keep this in mind. So if it's an abrupt change, stepwise decline, or gradual cognitive decline after one or more clinical events, such as stroke, is suggestive of a vascular type cause. However, minor strokes are often unrecognized as a cause for this. If they present with an acute, which is days to weeks, or subacute, weeks to months, that may suggest the presence of an infection, a metabolic disorder, an expanding brain lesion, the effects of medications, stroke to a lesser extent, or hydrocephalus. Creutzfeldt-Jakob also can be considered in this scenario, because Creutzfeldt-Jakob causes a decline within weeks to months in patients' cognition. And then if it's rapid, which is hours to days, that suggests that there's an acute confusional state or delirium, and obviously there are certain causes that need to be ruled out. So, other aspects to consider is that if there is an overall deterioration in the activities of the daily living and instrumental activities of daily living, this could be pointing us to a diffuse degenerative process, such as Alzheimer's disease, which starts in the temporal lobe but then affects most of the areas of the brain. But if we have a disproportionate decline in one area, that might mean that there is a focal cause. So things like strokes or tumors or frontal dementias who are more towards certain lobes of the brain. Frontotemporal dementias, for example, they have a predilection to affect the frontal or the temporal area lobes. So we need to consider that when we're assessing them as well, and just see if it's just global impairment or it's more in one area or two areas rather than globally. Family history, as I told you, is very important because it can point us towards possible genetic predispositions in the family. So early detection of that is important because that gives the patients a better idea about what to expect. Past medical history of systemic illness could sometimes put patients at high risk, as I explained to you earlier. Drug use, depending on the drugs, but some drugs, if there is a level of cognitive impairment, it can actually worsen it. And there are drugs, as I told you, mainly the anticholinergics, which we don't recommend using in elderly unless extremely necessary because it can worsen cognitive impairments. Obviously, you need to check for any risk factors for stroke, like history of previous strokes, TIAs, hypertension, coronary artery disease, atrial fibrillation. You also need to check for hypertension because it is having an association with increased risk of dementia, regardless or independent of cardiovascular diseases. And a detailed assessment of alcohol use is actually important, particularly in older patients with mild cognitive impairment, because that can give us an idea if this could be related to that. Now, an inquiry into a history of Parkinson's disease is important, as dementia is not uncommon in these patients. It's in about 80% after a disease duration of 10 years or longer of Parkinson's disease. And some patients with vascular dementia, they have transient neurological symptoms, and sometimes they have gait abnormalities, incontinence of urine at the initial time of assessment. So if you put these together, it could present a vascular dementia. With normal pressure hydrocephalus, the similar symptoms have been described, but they will be much more pronounced and usually coming together. So the gait disturbance and the urinary incontinence and the cognitive decline come together. And this is quite reversible, and you see dramatic improvement with treatment. Now, the cognitive examination, we usually use as a start MMSE, and this has been validated by a number of populations, and scores of 25 to 30 is usually considered normal. However, 21 to 24 is mild cognitive impairment, 10 to 20 is moderate, and anything below 10 is a severe cognitive impairment. There are other tools that we use, like MOCA and Alzheimer's disease assessment scale. These have been developed as screening tools, but we had a recent review, and that indicated that no one scale of these is superior to the others is in terms of the diagnostic accuracy. However, we need to keep in mind when we are doing these cognitive examinations for patients, regardless of which tool you use, is that we need to know about the educational level of the patient, because that can affect the outcome and make it look a lot lower than what it's actually going on. So we need to keep that in mind when we're assessing them. If you're not assessing them in their first language, chances are, and if they're not that advanced in speaking English and they express themselves better in Arabic or any of the languages that they speak, basically it's more likely that you will get a lower score because of that. So I've seen many patients in clinic where we actually, when we do it in their own language, and we try our best to either have a translator or a doctor who speaks the same language, and we can see that there is a difference in the scoring because of that. So we need to keep the educational level as well as the language in mind, and try to make it in their own first language, if at all possible, to get a more accurate and objective result. Now, in physical examination, when you examine these patients, you need to check if there's any visual field deficits that basically could indicate posterior cortical atrophy, could indicate strokes, pseudobulbar palsy, or what we label as involuntary laughing or crying, could be pointing to a Parkinsonian plus syndrome, which usually is associated with cognitive impairment and a primary progressive aphasia, and sometimes it overlaps with Parkinson's disease, with Alzheimer's disease. So we need to keep that in mind when we're examining them. Ataxia and nystagmus could indicate long alcohol misuse, lateral gaze palsy. And on motor examination, importantly, you need to check for rigidity, bradykinesia, which could indicate an ongoing Parkinsonian process, which could be either idiopathic or Parkinsonian plus. An abnormal speech or posture, because this again could be present in Parkinson or Parkinson plus syndrome. Sensory examination, the most important thing is if you find peripheral neuropathy, then chances are this patient either could be nutritionally deficient, B12, folate, and or there might be a long history of alcohol use, which again could present with peripheral neuropathy. Sometimes, again, if the diabetes is not well controlled, it can present that way, which gives you an idea that they have vascular risk factors that increases their likelihood of having vascular dementia. Coordination and gait abnormalities. So gait abnormalities, impaired vibration, position sense, all these could again point towards more nutritional deficiency and or alcohol misuse. Spasticity and paresthesias could be pointing us toward an inflammatory cause like multiple sclerosis if this has not been already diagnosed. Reflexes, so primitive reflexes like glabellar grasp and snout reflexes, all of these are seen quite a lot in Alzheimer's disease, especially the advanced stages. Any generalized myoclonus or Stalter response specifically, these tend to get noted in Creutzfeldt-Jakob disease. So it's important to try to assess for this just to make sure this is ruled out, especially depending on the history of the patient. But if it's been a few weeks to few months, this is something to keep in mind when you're assessing. And then hearing test if possible, because hearing loss from central auditory dysfunction might be one of the reasons, and that could be relating to a neurodegenerative process rather than an ear problem that's preventing them from hearing very well. And importantly, cardiovascular examination. So we need to check for hypertension, dysarrhythmias, peripheral vascular disease, valvular disease, or congestive heart failure, because all of these can contribute to the development of cognitive impairments and eventual dementia. Now, psychiatric evaluation is usually to check the global functional status. How is their mood like? How is their affect like? How is their thought process and thought content? We see a lot of social withdrawal and paranoia, as well as anxiety in Alzheimer's disease. In vascular dementia, we see more depression and delusions, as well as emotional incontinence, where they can't keep their emotions very well controlled. In Pick's disease, we see personality changes, disinhibited behaviors, and social withdrawals, and they have lack of insight to all these changes. And the Parkinson's disease dementia predominantly presents with mood and psychotic symptoms more than any of the other neurodegenerative diseases. Part of our clinical approach is obvious, making sure that we order the correct investigations, but starting with neuropsychological testing is important, and that we usually do hand in hand during the memory clinic in certain centers in the UK, where they do them together. So the patient gets seen in the memory clinic and then immediately goes and gets the neuropsychological testing. In other centers, we do a direct referral. So if we feel like the patient requires further assessment to see if there are certain domains that they're more deficient in, then we need to refer them to neuropsychology, and they usually see them shortly after. And then we have an MDT meeting to discuss all these findings and then reach a conclusion of what this patient is most likely to have. Obviously, if there's any strong family history, we need to do genetic testing, as I told you. And EEG is sometimes used if there are results that are equivocal. And usually in neurodegenerative diseases like Alzheimer's disease and Lewy body dementia, we see a generalized slowing of the background rhythm in EEG. Now, this table summarizes what you need to do if someone presents with delirium or cognitive impairment, in terms of history, as well as the workup that we need to do. So we've discussed some of them, but what you need to definitely check is thyroid function tests. As I told you, B12, electrolytes, and we need to do imaging just to see if there is any specific lobar atrophy. We need to do a lumbar puncture only if, again, we're not quite sure about what's going on, because some patients are not straightforward. Some patients have a mixture of symptoms that don't fit under specific category. So lumbar puncture can usually help us. It's still in the research phase. It's not been used as a gold standard to detect this, but sometimes the levels of tau, the levels of alpha-synuclein could potentially help us understand what's going on better. Liver function, renal function, all of these is very important because the impairment in these functions could cause encephalopathy and cognitive impairment. Urine toxin screen, HIV, syphilis screen, all of these things need to be considered in this context. Apolipoprotein E is something that if you have more than one allele of, you're more likely to develop dementia. So you are at a higher risk if you have this, but that doesn't necessarily mean that you're destined to have dementia in the future. Things that you could possibly want to add, depending on the presentation, depending on your clinical examination findings, like parathyroid function, adrenal function. As you know, with adrenal insufficiency, there is hyperpigmentation, patients is constantly tired, blood pressure is always low. So if you see things like that, also always check cortisol, because that by itself could present with cognitive impairment. And that could have multiple causes, and that needs to be explored during history. SPECT and PET scans can be quite helpful because the uptake, if it's decreased in certain lobes in the brain, that gives us an indication of what this kind of dementia could be. Rarely we do brain biopsy to try to figure out what's going on, and that's usually post-mortem. But if there is any kind of clinical question about what's going on, despite doing all of these tests, then they might consider doing brain biopsy, but this is quite rare. So the reversible causes is usually things like hypothyroidism, thiamine deficiency, B12 deficiency, normal pressure hydrocephalus, because if you put a shunt, you basically solve the problem and they go back to being normal. Subdural hematomas, which we see quite often, chronic subdural hematomas in elderly patients because they have falls. Sometimes they don't attend the hospital. It's small hematomas, but it could, if the patient has more than one, and they're chronic in nature, they could present with variable cognitive impairment, any chronic infection or drug intoxication. All these could potentially be reversible causes. But Alzheimer's, frontotemporal, Huntington, Lewy body, vascular, Parkinson's, all of these are unfortunately degenerative and highly unlikely to be reversible in nature. As I told you, CT and MRI is something we usually do to assess, because that by itself sometimes could be enough if it shows us any atrophy or any vascular changes. PET and amyloid PET scans are helpful in basically cases that are equivocal or where MRI did not show anything that is leading in one direction. So that helps us, especially with the amyloid. It's making a promise in making an earlier and more accurate diagnosis of Alzheimer's dementia. And if needed, as I told you, it really depends on the nature of the presenting. And that's why I'm just giving you a comprehensive clinical approach here, because this could be used for assessing patients with delirium, as well as cognitive impairment. So it depends this encompasses acute, subacute, and chronic, and it's something just to think of along these lines when you're assessing these patients. CSF can be done to rule out things like demyelinating illness, whether it's acute or subacute, a typical or rapidly progressive initial manifestations, or if there's a dementia in people who are less than 55 years old with no family history, suspected syphilis, suspected infection or malignant lesion, patients with evidence of hydrocephalus, Creutzfeldt-Jakob, demyelinating diseases, and vasculitis. If you're suspecting any of that, you have to do a CSF. And the diagnosis of dementia, as I told you, confirmed by post-mortem neuropathological assessment of the brain, but we rarely do a brain biopsy to try to confirm a diagnosis because it's invasive and it will not add to the management. Essentially, what I need you to know from this, because that has quite a lot of things, what I need you to know is with AD, the first symptom they present with is memory loss. With frontotemporal, it's more apathy and poor judgment and insight, hyper-orality, speech and language issues where they are either fluent or non-fluent. With dementia of Lewy bodies, they have more visual hallucinations, REM sleep disorders, Parkinsonism features. If it's Creutzfeldt-Jakob, they usually will have dementia, mood, anxiety, and movement disorders, specifically myoclonus. And if it's vascular, it's variable, but it includes apathy, falls, and focal weakness. And they have specific changes on imaging, but as you may expect with Alzheimer's, it's temporal lobes that are mainly involved and the hippocampus. FTD affects either the frontal or the temporal or both. And the CJD, the important thing you need to know is cortical ribboning on imaging, because this is a sign not always seen. So that doesn't, if it's not there, that doesn't mean they don't have Creutzfeldt-Jakob. Creutzfeldt-Jakob is conferred by CSF, but if it is there, that confirms that there is a diagnosis of CJD. And dementia with Lewy body is diagnosed as dementia with visual hallucinations, Parkinsonism, fluctuating course with the Lewy bodies on pathology. The way you differentiate between Lewy body dementia and Parkinson's disease dementia is that if the Parkinsonism is present more than 1 year before the cognitive impairment is detected, then the diagnosis will be Parkinson's disease dementia. It's just which comes first, the cognitive impairment or the Parkinsonism, that helps us differentiate. This again summarizes, if you're interested about what presents in different types of dementia in terms of history, the memory, the language, the conduct, the motor skills, and then the findings on different types of imaging that we do, most of which we have discussed already, not in so much detail, but what you need to know at this stage. Now, having finished the history, physical, and the workup to assess these patients, what do we do in terms of management? The most important part in the management of any disease is to be holistic, and specifically in this, because our major goal is really to treat the correctable causes and provide comfort and support to the patients and the caregivers. And we treat any underlying causes or things that might make it worse. So thyroid replacement for hypothyroidism, vitamin replacement for B12 or thiamine deficiency, antimicrobials for opportunistic infections, antiretrovirals for HIV, shunting for normal pressure hydrocephalus, radiation chemotherapy for CNS neoplasms. As I explained earlier, they would present with things like depression and anxiety, and antidepressants such as SRIs, which features anxiolytic properties as well, but few cognitive side effects, provides a good way to manage depression in these patients. And anticonvulsants are used to control seizures because, unfortunately, with patients with advanced Alzheimer's dementia specifically, we see more prominence of seizures, and usually they're generalized tonic-clonic seizures. So sometimes we need to use anticonvulsants to help try and control that. That doesn't happen with everyone, but we see it more commonly in patients with advanced dementia. Now, before I continue with that, because we're discussing holistic, one thing I wanted to point out, which we were trying our best to help incorporate it in our healthcare system is there are things that happen very early on in the patient's life that actually impacts their chances of getting dementia in the future. And we need to keep that in mind, because what we want is to try to be more preventative in managing any condition in medicine, rather than just treating it as and when it happens. And something that unfortunately now has been more prominent in our generation and happening a lot more frequently is that patients or people, individuals, when consume large amounts of processed foods, large amounts of sugar that is way above what's required on everyday life. There isn't a lot of exercise or movement. Sleep is not always a priority, so sometimes there's problems with sleep that are not being dealt with, and people are not getting enough sleep. All what I just mentioned right now, if you imagine that they're all happening together sometimes, or more, one happening more than the other, but happening over a very extended period of time. So I'm talking since the teenage years. If you are constantly having all these risk factors ongoing more and more and more, and we're not really trying to manage them, or patients are not trying to change their lifestyle, chances are we are causing permanent damage. And that permanent damage, because as you may know, the foods you eat can really impact the biochemical basis of your entire body, and that by itself can affect the brain. So having things that are high in sugar increases insulin resistance, and insulin resistance has a very important role in the biochemical basis in the brain, and a misfolding in protein, which is still being studied, but that could affect how our body clears things. So if we have that constantly in our body, chances are this is what's happening. Also, there has been an explosion in the research on microbiome, and how changes in that relating to what kind of food you eat can really impact the brain, because there's a direct connection through the vagus nerve, and that by itself could potentially present problems with folding the proteins, which is the basis of many of the neurodegenerative diseases that we have. So we need longer observational, longitudinal uh, research to be able to make these connections and check how strong they are. But patients who have any of these problems, whether it was with food, with lack of movement, with sleep issues, where they're not getting enough sleep and rest so their brain can recuperate, because our brain removes all the toxins that goes in our system. The brain tries to recuperate overnight. So if you're not getting enough sleep, you're not having a good quality sleep, you are increasing all of these abnormal processes of abnormal protein folding happening, and therefore many of the neurodegenerative diseases could be related to that. So I just wanted to highlight that, because now this is an exploding area of research, specifically in neurodegeneration, specifically microbiome. So always make sure to check about the patient's diet, about the patient's lifestyle, and the quality of their sleep, because if we work with these things, we could at least prevent further damage. And if we can pick up on these things a lot earlier, that can help us prevent dementia to begin with. Or even if it happens, it's not going to be as prominent in these patients. And also keeping themselves stimulated and busy, because that we've seen a lot of patients who would have significant changes on the MRI, but you barely see any symptoms because they have a good cognitive reserve. All of these things play very important roles. So I just wanted to highlight these, because it's important to know that this is a very long ongoing process. It doesn't happen overnight. So we need to look back and see what can we do to change these factors to prevent these diseases, or at least prevent the severity of these diseases for the patients. Now, moving on from that, behavioral symptoms, we should aggressively seek out modifiable environment or metabolic factors. So hunger, lack of exercise, toothache, constipation, UTI, drug toxicity, they are all easily correctable. So we need to make sure that if they're there, that we treat them, because that can really quite be helpful without any use of psychoactive drugs. Things like benzodiazepine may ameliorate the behavioral, but they have side effects of sedation, rigidity, dyskinesia, and sometimes paradoxical disinhibition, especially with benzodiazepine. So we need to be careful. If we can treat any of the factors that could potentially be causing these behaviors, then we don't need to use any drugs. Second-generation antipsychotics, such as quetiapine, could be used for patients with agitation, aggression, and psychosis, although the risk profile for these compounds is significant, so we don't prefer to use them unless is really required. And when patients do not respond to treatment, it's a mistake to advance at higher doses or to use anticholinergics or sedatives to help them, because chances are we're making the cognitive impairment a lot worse. Sometimes apathy and visual hallucinations and other psychiatric symptoms, they do respond to cholinesterase inhibitors, and that's specifically in dementia of Lewy bodies, obviating the need for other more toxic therapies. So cholinesterase inhibitor rivastigmine is the most commonly known one that we use specifically for Parkinson's disease dementia. It's quite helpful. And for Alzheimer's, we usually use donepezil and galantamine. Memantine also proves useful when treating patients with moderate to severe Alzheimer, and we saw that it's most likely affecting the caregiver burden by decreasing it, because there's decreased resistance to dressing and grooming support. We need to have a proactive strategy. So with occupational health, that can help the patient with frequent orientation, cognitive activities, sleep enhancement measures, vision, hearing aids, and correction of dehydration. All of these things are very important to try to keep things under control. We need to explain all of these things to the patient and their family and try to provide them with as much support as possible, and allow them to have different resources for counseling. There are local and national support groups such as the Alzheimer's Association, and that can provide considerable help for patients and their caregivers. Basically, most of what's on here I've already discussed to you. So the treatment of different types of dementias. Lastly, knowing about the prognosis. It's a progressive disease at the end of the day. It helps us predict the prognosis and allows the patients to be managed better in their psychosocial setting. The cholinesterase inhibitors in Alzheimer's disease and dementia with Lewy bodies is very well established, so it is quite helpful, and can improve the behaviors and delay progression. Correct diagnosis will aid with appropriate pharmacotherapy, so we don't end up causing worse outcomes for patients. And behaviors in dementia with Lewy body can improve with cholinesterase inhibitor therapy. So as you can see, accurate diagnosis may spare the inappropriate and even harmful usage of antipsychotics for the management of behaviors in dementia, specifically in dementia with Lewy bodies. And that concludes the dementia and delirium. I'm going to run through this quite quickly because you're not expected to know about these things in detail, but it's good to just have a bit of an idea about the auditory and visual cognitive impairment that patients may experience. I just wanted to check if anyone has any questions at this stage before I continue. Okay, I'll proceed to the rest, and I'm more than happy to answer any questions towards the end of the session. Thank you. Okay, so the most important thing for me for this is for you to be able to appreciate the differences between aphasia, dysarthria, and apraxia of speech. Aphasia is usually a selective impairment of language or the cognitive processes. And they usually have language problems, but they also have at least equally severe deficits in the episodic memory, visual spatial skills, and organization skills. Dysarthria, it's a problem with speech production due to the weakness, slowness, reduced range of movement, or impaired timing and coordination of the muscles of the jaw, the lips, tongue, palate, vocal cords. So there isn't any proper coordination, and there is probable weakness that presents the dysarthria. Apraxia of speech, it's an impairment in the motor planning and programming of the speech articulation, which we cannot really relate to dysarthria. So these are three different kinds of speech problems that we frequently encounter in dementias. What we usually see is semantic, with aphasias, we have semantic paraphasias when they substitute a semantically related word for a target word, like calling a horse a cow. There's phonemic paraphasias where they substitute one or more sounds in the word, like, for example, calling horse a force, or using a word that doesn't exist, like a porse. Neologisms is a series of sounds that do not compromise a word and are not similar to the target word in any way. Circumlocutions are calling, for example, a horse an animal that you ride with a saddle. So they can explain what it is, but they cannot say the word. Now, the ones that you're already aware of is the fluent aphasias, Wernicke aphasia, where they have a problem with comprehension, but they can speak very fluently, but it's jargon. The non-fluent, they're usually called Broca's aphasia, and they're able to comprehend very well. They just cannot form full sentences, and they usually are able to answer with yes or no, but they're not able to talk fluently. And these could be seen in stroke as well as in dementia. And this just summarizes what happens in different kinds of aphasias in very much detail in terms of naming, fluency, and comprehension, as well as repetition. We don't need to go into that in detail. Some of the many risk factors or etiologies for this is similar to dementia. And we need to urgently consider, when someone presenting with aphasia, we need to consider things like acute stroke, subarachnoid hemorrhage, intracranial hemorrhage, Wernicke encephalopathy, which I explained about earlier, herpes encephalitis, because all of these could present with aphasia. So we need to check for that. And the clinical approach for this, in terms of history, if they are having a rapid onset with pure nutrition, we need to suspect Wernicke's encephalopathy. If it's a rapid onset fluent aphasia, this could be a herpes encephalitis until proven otherwise. So we need to consider that when we're assessing. Aphasia due seizure or migraine may appear in patients with a history of epilepsy or migraine headaches. And there are migraines that have speech auras where the speech is halted and they cannot speak. So this is something to also consider in patients who have a history of that. Aphasia is an atypical presenting feature in prion disease or Creutzfeldt-Jakob. Weight loss sometimes can either point us to cancer or nutritional deficiency that could present with aphasia, or tumor or Wernicke's encephalopathy. An impairment of language over at least 2 years, followed by the onset of other cognitive problems, that suggests usually a neurodegenerative disorder like Alzheimer's and primary progressive aphasia. When you examine these patients, you need to make sure to check for any fever or tachycardia to indicate an infection, any neck stiffness to indicate subarachnoid hemorrhage or meningoencephalitis. Are they depressed, apathetic, or have a manic effect? That could be in stroke or in dementia. Are they having any cardiac arrhythmias, any peripheral pulse deficit, any carotid bruit? This is mainly vascular, but could be central nervous system-like disease. And then traumatic aphasias may be accompanied by typical findings of head injury you can see on physical examinations, such as bruises, fractures, CSF rhinorrhea. So you need to check for all of that when you examine the patients. And obviously check for ophthalmic signs, because this could be pointing either towards a stroke or Wernicke's encephalopathy. If it's an intranuclear ophthalmoplegia, that suggests a multiple sclerosis. And if they have visual field defects, it could be in stroke, it could be in migraine sometimes. So we need to check for all of this, which is the cranial nerves, while we're doing physical examination. Then, because it's aphasia, we need to check for things like the quality of the spontaneous speech. How are they with naming, repetition, so you can show them pictures and ask them to name. Are they able to repeat after you or not? Are they comprehending what you're talking about in detail? Are they able to read and write, or is that impaired as well? Because that gives you an idea about what exactly is going on in terms of the language domains and what are affected. Obviously, with this as well, we need to evaluate cognition, check for upper motor nerve and cranial nerve findings, and evidence causes of both vascular and non-vascular aphasias. Ataxia, lower motor neuron deficits, all of these could help direct us towards narrowing down the differential diagnoses. because it could be quite wide of what's causing this. If it's in it could be infectious, as I told you. It could be cancer. It could be sarcoidosis, multiple sclerosis. So we just need to keep all of this in mind when we're assessing these patients. And obviously, again, we need to do CT and MRI with and without contrast to check for any underlying causes. Angiography could be helpful if we're suspecting a vascular cause, like keratostenosis causing a stroke, for example. Obviously, chest X-ray and CT chest is quite helpful in these circumstances to rule out any primary cancers or any primary causes of sarcoidosis, for example. The echo, as well as the bubble study to check for the patent form and ovale, could be quite helpful if we're actually assessing for stroke, because there will be embolization as a result. And obviously, lumbar punctures, EEGs are quite helpful, as I explained to you before. EMG is used if we're suspecting an ALS pathology, which could come with frontotemporal dementias that could present with fluent or non-fluent aphasias. And things like glucose and thiamine are always helpful in these circumstances to rule out any Wernicke's encephalopathy. Now, the most important thing for you to know is for management of these patients, the one way that has been proven to be quite helpful is the constraint-induced aphasia therapy. And basically, it's forced use of verbal oral language as the sole channel of communication. So other ways like writing, gesturing, or pointing, we prevent them from doing that, just to try to get them to be able to do that without using anything else. So that pushes them slowly to be able to return some of their language back when they have stroke. And the response generally for speech and language therapy is very variable, depends on the extent of the issue, the nature of what's going on, whether it's stroke or non-stroke, and the patient's age, other comorbidities. These all play a huge role in how we manage these patients. Alzheimer's disease, most importantly, I just need you to know that they could present with a logopenic variant, so they will have problems with speech. So this is something to consider. With Alzheimer also, as I told you, there's a posterior cortical atrophy, which is a visual cognitive impairment where they're not able to see, but sometimes can confabulate, and they're not aware of this problem usually. And these could be presentations of Alzheimer's disease, and that's why we just need to be aware of them. And as I explained to you earlier, frontotemporal dementias can present with fluency problems or fluent but comprehension issues. And sometimes it's purely behavioral, where they have hyperorality, hyperphagia, hypersexuality, and sometimes these overlap, so they can present with behavioral changes as well as language problems. And these are all domains that we need to assess when we're checking for dementia, to be able to understand. And that's why all these tools for cognition have all of these at hand, because we need to understand which domains are severely affected, because that can really narrow down what exactly is going on. So this concludes my presentation. These are just some questions for you at the end of the session, just to test your knowledge with it. So we have a 72-year-old male diagnosed with dementia after a 1-year history of progressive cognitive decline, particularly in planning, cognitive flexibility, attention, visual memory, visual spatial manipulation, on detailed assessments. His mini mental state examination score is 15 out of 30, which is the moderate cognitive impairment, and he has Parkinson's disease and was given Medipar 6 years ago, and he's well on that. His son attends clinic with his father, and both are very keen to start some treatment. What do you think is the most available treatment that would be quite helpful here? Very good, quite correct actually. Rivastigmine is usually very helpful in these circumstances, as explained to you earlier. Now, the second question is an 80-year-old man was brought to the hospital after a collapse. A carer in his nursing home reports he became pale and slumped, unresponsive in a chair, but regained consciousness after a few minutes. He's known to have hypertension, hypothyroidism, mild dementia, and previous seizures 15 years ago. When the paramedics arrived, they report a heart rate of 34, which has now resolved. Examination reveals a normal heart sounds, capillary refill of 3 seconds, and a regular pulse of 60. Which of his medications may be responsible for the collapse? And I want to highlight that you can see a heart rate of 34 per minute. Which one of these is most likely responsible for that? So I can see some of you have put bendraflumethiazide. Now that by itself could cause a collapse because it can lower the blood pressure. So I understand your thinking process, but if we're looking at the bigger picture, donepezil is known to cause bradycardia. So actually, before starting on donepezil, we need to check that the patients don't have an established bradyarrhythmia or bradycardia, because if they do, we cannot start this because this could bring down their heart rate to a very dangerous level, such as what happened here. And thankfully, it was just temporary. But we need to make sure we assess patients for this before we start something like donepezil, which is started quite a lot with patients who have dementia. But good shout for everyone who has tried. Thank you so much for your participation. And then we move to the last question of the day, which is an 88-year-old woman is brought by her daughter as her memory has been deteriorating over the past year. Upon clarification with her daughter, it is confirmed that the patient has deteriorated over many months and has not had an acute illness. She has no significant past medical history apart from an appendectomy when she was a teenager. When you examine her, the patient is comfortable at rest. She's not pyrexial. She has a heart rate of 70 and the blood pressure of 115 over 90. What do we include in her initial screen apart from the hematology and biochemistry? So obviously, keep in mind this is an elderly lady, cognitive impairment over 1 year at least. What do we need to make sure of to rule out at the first instance? All right, so your responses are a mixture of almost all the answers. Essentially, what we need to be looking at, definitely the first three are something that is unifying. So we need to check all the first three: the thyroid function, serum B12, and folate. Syphilis is usually checked as part of the workup. It's just, for example, things like HIV, unless we think the patient might have been exposed or there is a risk for that, we don't generally check it for the purpose of assessing for dementia. Lumbar puncture, as I told you, we tend to do it, but not very often. It's if it's an equivocal or we don't have any thing to explain on things like the blood tests and the MRI or the imaging, then we think about doing a lumbar puncture. This is not something that we routinely do, so we wouldn't do a lumbar puncture. So that basically, with that being said, lastly, the midstream urine is something we do because, with elderly, sometimes cognitive impairment could be related to urinary tract infection that we see quite significantly. So usually thyroid function tests, B12, folate, syphilis, and midstream urine would be what we start with. And then if we need to do any further investigations, depending on the nature of the presenting symptoms and whether there is a risk or not to specific things like HIV, and whether there's equivocal result in imaging, then you go for lumbar puncture. But the third option is the correct option because it has the most important things that you need to assess at the initial stage of anyone presenting to you with cognitive impairment. Thank you so much all for your participation and for listening. These are my references, and I really appreciate you listening. And I hope that was helpful to you in just approaching in a correct way for patients who present with delirium, as well as aphasias, and how to work them up in a more general approach. And if you have any further questions about this, or anything regarding internal medicine training, neurology training, or academic clinical fellowships or academic pathways, I'm more than happy to be contacted by email. Thank you so much for listening, and I do hope you have a lovely evening ahead. Thank you. Thank you. If you have any questions, please do let me know. You can pop them in the chat, and I'm more than happy to answer. So I'll stay for a few minutes after now. Thank you.